I'm Dr. Tom Kulik. I'm a pediatric cardiologist and cardiac intensivist at the Children's Hospital Boston. This lecture will be the second part of two lectures in regards to the diagnosis and management of the infant with cyanosis.
Introduction.
To briefly preview the lecture, we will first review the physiology of cyanosis that was covered in the first of these two lectures. We will discuss general diagnostic considerations. We will briefly go over some of the most important types of cyanotic heart disease, especially the types that are present in the neonate. And we will discuss ICU-based therapy. And by that, we're not going to talk about surgical palliation or surgical correction of these lesions, but rather focus on the sort of things that the neonatologist and intensivist will be involved with in their unit, stabilizing and preparing the baby for more definitive treatment.
Physiology.
So let's briefly talk about the physiology of cyanosis caused by congenital heart defects and review material that we had previously discussed. There are basically four types of physiological reasons why babies are cyanotic. They can have right to left intraventricular shunt, as illustrated here, by a baby with tetralogy of Fallot. In this case, there's a ventricular septal defect and outflow obstruction between the right ventricle and pulmonary artery. Hence, blood tends to go right to left across the VSD into the aorta. Right to left intra-atrial shunting. In this case, it's a baby that has severe pulmonary stenosis. The obstruction to blood flow from the right ventricle to the pulmonary artery is so severe that an entire cardiac output cannot be ejected into the lungs, and hence there's a considerable amount of right to left shunting at the atrial level, not ventricular level. Let's talk about what I might term simple, or perhaps more commonly termed complete mixing. And what you see here is an example of a baby that has a particular type of single ventricle lesion called tricuspid atresia. In this case, there is what I might term simple or complete mixing of blue systemic venous blood with red pulmonary venous blood, and as a result, there is a cyanosis. And finally, transposition physiology is the physiology that occurs in babies that have a detransposition of the great vessels. That is to say, the aorta is attached to the right ventricle and the pulmonary artery to the left ventricle, in which case there tend to be two separate circuits whereby the blue blood coming back from the body to the heart is ejected right back out to the body again, and red blood from the lungs is re-ejected to the lungs. These patients can only survive ex utero by virtue of some degree of mixing of the red and blue streams, and we will discuss this a little bit more in just a few minutes. There are multiple determinants of arterial oxygen saturation in congenital heart disease, and they can pretty much be boiled down to these five factors. The first is pulmonary venous oxygen saturation. Obviously, a baby with a congenital heart lesion will be bluer than he or she would otherwise be if there's lung disease, and hence the pulmonary venous blood is not fully saturated. The ratio of pulmonary to systemic blood flow, also known as QP to QS, is very important in babies with either complete mixing lesions or even simple right to left shunting. The amount of systemic blood flow, the hemoglobin content of the blood, and the total body O2 consumption are also important in determining arterial oxygen saturation. And the reason for this is that whenever there's right to left shunting, the blue blood returning from the body tends to essentially dilute out the oxygen level of the red blood returning from the lungs. The bluer the blue blood is, the less red the arterial blood will be as it's ejected from the heart. So as systemic blood flow falls, mixed venous oxygen saturations also tend to fall. With less O2 delivery to the body because of lowered hemoglobin, the mixed venous O2 saturation tends to fall. And as more oxygen is extracted because of high oxygen consumption, that also tends to negatively impact the oxygen saturation of the venous blood. So these are the key determinants of arterial O2 saturation in just about any congenital heart lesion. Perhaps the only exception to that is detransposition of the great arteries. And there the key issue is how much mixing of the red blood and the blue blood streams occurs. And again, we'll talk about this a bit more in a few minutes.
Diagnostic considerations.
Let's move on to general diagnostic considerations. We're going to focus primarily on the clinical characteristics which help discriminate congenital heart disease from lung disease and persistent pulmonary hypertension of the newborn. We're not going to try to provide enough information to allow one to make a specific diagnosis of a heart defect without performing an echocardiogram, because echo is really the definitive way we make these diagnoses in the vast majority of cases. So I'm going to emphasize for the next few minutes the things that one can observe in a baby in terms of physical signs and symptoms that make one most concerned about the possibility of a congenital defect, and hence initiating prompt detailed evaluation of such. So let's talk about these red flags for congenital heart disease. The first is babies that are cyanosis with what one of the kind of founding fathers of pediatric cardiology, Alex Natus, termed happy tachypnea. Happy tachypnea is tachypnea without dyspnea, or a baby who's breathing fast but very easily. Babies with lung disease, of course, tend to have dyspnea because their lungs are relatively non-compliant. On the other hand, babies with congenital heart disease tend to have very compliant lungs, and hence, although they will be tachypnic because of a hypoxic respiratory drive, they don't tend to breathe particularly hard. And so happy tachypnea tends to make one think more of heart disease and less of lung disease. Now, one has to be careful, though. There is a particular type of heart lesion, total anomalous pulmonary venous connection. That is to say, when all the pulmonary veins returning from the lungs have obstruction somewhere between their origin and the heart. These babies can develop very severe pulmonary edema, as is illustrated on this chest X-ray of a young patient with total obstructed veins. And these babies will have a considerable amount of dyspnea. So one always has to keep obstructed total veins in mind when presented with the cyanotic baby that has lung findings suggestive of pulmonary edema. The second red flag for congenital heart disease is differential cyanosis. Differential cyanosis is when the oxygen saturations are different in the right arm versus the lower body. And there are basically two types of differential cyanosis. The first is differential cyanosis due to right to left shunting of systemic venous blood into the descending aorta. And this can occur under two circumstances. One is persistent pulmonary hypertension of the newborn. Babies that have this particular disease have very high pulmonary resistance, and if they have an open ductus, especially a large open ductus, they may actually shunt blood from the pulmonary artery into the descending aorta, such that their oxygen saturations in their right arm will be considerably higher than in their legs. Not all babies with PPHN have differential cyanosis, but certainly many of them do. Those same findings, however, can occur in babies with congenital heart lesions. For example, I've shown a baby with interruption of the aortic arch. In this particular set of circumstances, all of the perfusion to the lower body is via the right ventricle across the ductus, and so these kids will tend to have substantially lower oxygen saturation in the lower extremities than in the right arm. So differential cyanosis, while it can occur without a congenital heart lesion, specifically with PPHN, can also occur with certain forms of heart disease. The second flavor, if you will, of differential cyanosis is reverse differential cyanosis. And with reverse differential cyanosis, the oxygen saturations are actually higher in the lower body than in the right arm. And where this is occasionally seen, and I think pretty much the only time it's occasionally seen, is in babies with detransposition of the great vessels or a very similar anatomic lesion. In this case, if there is very high resistance to blood flow in the lungs and there's a patent ductus arteriosus, when the left ventricle ejects blood into the pulmonary artery, a certain fraction of it will tend to go across the ductus into the descending aorta. Since this is red pulmonary venous blood, these patients will actually tend to have higher oxygen saturation in the legs than in the right arm. This can occur either because, as I just mentioned, high pulmonary vascular resistance, or sometimes coarctation of the aorta in a detransposition, where there's narrowing of the isthmus of the aorta, the segment between the left subclavian artery and the ductus. And that can also give reverse differential cyanosis. So the finding of reverse differential cyanosis is very highly suggestive of congenital heart disease. Murmurs are a third, can constitute a third red flag for congenital heart disease. As I think most folks know, very soft murmurs are very common in babies, and grade 1 to 2 over 6 murmurs do not necessarily connote congenital heart disease. On the other hand, murmurs of grade 3 intensity or louder are quite unusual and otherwise normal babies, and certainly raise a red flag in a baby who has lower than normal arterial oxygen saturations. Continuous murmurs in the back are also very uncommon in otherwise normal newborns and make one think of a lesion like tetralogy of Fallot with pulmonary atresia. And there is one murmur in particular, that is to say the to and fro, not so much continuous, but to and fro murmur at the left upper sternal border, which is almost pathognomonic of babies that have absent pulmonary valve syndrome, also known as tetralogy of Fallot, absent pulmonary valve. There are very few other situations in which a typical to and fro murmur like this is heard. So murmurs can sometimes put one on the alert for congenital heart lesion. Point number 4 refers to the so-called hyperoxia test. That is to say, if one gives a baby with lung disease a very high inspired oxygen, generally the PO2 will go up substantially, or the O2 sat goes up substantially, by virtue of the fact that most babies that are cyanotic by virtue of lung disease have VQ mismatch as a primary cause for this, and this is quite responsive to oxygen. One can read various cutoff levels for arterial PO2 in response to 100% oxygen as discriminating between congenital heart disease and lung lesions. I've used PO2 of 200 because it's certainly possible for babies with cyanotic mixing lesions to have PO2s of greater than 150 on 100% oxygen. But to be quite honest, this test doesn't have a clear-cut cutoff. Babies with very severe lung disease may not increase their arterial PO2s that much on 100% oxygen. On the other hand, babies with certain forms of heart disease, for example, total anomalous pulmonary venous connection below the diaphragm, will occasionally have streaming of pulmonary venous blood in such a way that the arterial PO2 can actually be greater than 200 in the upper body. And so it's very hard to give it a discrete, reliable cutoff for the hyperoxia test. I think it would be safe to say that any PO2s less than 200 or even somewhat greater than that would make one have to consider the possibility of congenital heart defects. And in fact, probably a more sophisticated way to think about this, although a non-quantitative way, is to consider that whenever the arterial PO2 is out of proportion to the chest X-ray, one is concerned about congenital heart defects, in particular relatively low PO2s despite a normal chest X-ray. Again, one has to be cautious. Babies with obstructed total anomalous pulmonary venous connection can have very wet appearing chest X-ray, which might imply pneumonia, but in fact is pulmonary edema due to their congenital heart lesion. Electrocardiogram is generally normal in most babies with cyanotic heart disease and isn't terribly useful in most cases, therefore, although the presence of left axis deviation, that is to say a QRS axis of less than 0, does run along with certain forms of heart disease, cyanotic heart disease, especially tricuspid atresia, and certainly raises a red flag in the circumstances in which left axis deviation occurs. Finally, the chest X-ray can be helpful. Certainly dextrocardia doesn't prove the presence of congenital heart disease, although makes it quite likely. A midline stomach bubble, as one sees with heterotaxy syndromes, also markedly increases the likelihood of congenital heart disease. A right aortic arch can be a finding in a normal person, but it also suggests the possibility of tetralogy of Fallot, truncus arteriosus, or transposition VSD pulmonary stenosis. And a classic finding with babies that have tetralogy of Fallot, or tetralogy of Fallot with pulmonary atresia, is the upturned cardiac apex combined with a flat pulmonary arterial segment on the chest X-ray and right aortic arch, as we see in this film of a baby with tetralogy of Fallot and pulmonary atresia.
Types of cyanotic congenital heart disease.
So having discussed the sorts of physical findings that make one concerned about heart disease, let's talk about the specific types of heart disease that are cyanotic heart disease that occur most often in babies with this lesion. We're not going to go over detailed descriptions, but I hope to provide enough information that you'll have a general idea of what you will be dealing with about 99% of the time when dealing with cyanotic infants. And I'd like to break these lesions down into what you might call a ductus-centric classification. That is to say, categorize the babies, the patients in this way. Those that have severe obstruction to pulmonary blood flow and therefore require an open ductus and therefore prostaglandin E1 for a palliation. Number 2, babies that have little or no obstruction to pulmonary blood flow, in which case PGE1 may not be either required or even helpful. The third type classification are babies with detransposition of the great vessels. Those babies may benefit from an open ductus, but not always. And finally, babies with a total anomalous pulmonary venous connection with obstruction. In those cases, babies neither benefit from, in fact, may actually have a deleterious effect from prostaglandin E1. So let's start with the first classification, babies with obstruction, severe obstruction to pulmonary blood flow, in which case prostaglandin E1 is required therapy. The first would be babies with critical pulmonary stenosis or pulmonary atresia. As I mentioned earlier in this lecture, babies with this particular lesion have such a high degree of outflow obstruction between the right ventricle and the pulmonary artery that a full cardiac output cannot be ejected across this narrowed pulmonary valve into the lungs, and hence there's a very large amount of right to left shunting at the atrial level. There's a diagram of that on the left. On the right is a lateral view of an angiogram, which is an injection into the right ventricle. And what you see here is a good-sized right ventricle, but with relatively heavy trabeculations due to hypertrophy that's occurred in utero because of the very high right ventricular pressure. and you see a very thickened pulmonary valve. Ordinarily, you can't really see the pulmonary valve very well on angiography, and with a relatively small jet of contrast that goes across it. This is a kind of a typical angio of a baby with critical valvular pulmonary stenosis. Because of the marked limitation in pulmonary blood flow in critical PS, patency of the ductus is critical. Tetralogy of Fallot, if severe enough, can present with life-threatening hypoxemia in a neonate because of a marked reduction in pulmonary flow. I want to make the strong point, however, that most babies with tetralogy, after they're born, do not have severe obstruction to right ventricular outflow. Most neonatal tetralogies have quite adequate oxygen saturations without an open ductus and really require very little in the way of therapy. But in the case of a baby with severe obstruction, prostaglandin E1 may be required. There are other lesions that are similar to tetralogy Fallot, for example, double outlet right ventricle with pulmonary stenosis, that have much the same physiology. Babies with single ventricle lesions that have a high degree of obstruction to pulmonary blood flow also require prostaglandin E1s. This is a diagram of a patient with tricuspid atresia. In the case of triatresia, there is basically no right ventricle, no tricuspid valve, and so systemic venous blood goes from the 2 cava into the right atrium, crosses the atrial septum into the left atrium, and mixes with pulmonary venous blood there. Enters the left ventricle, some is ejected into the aorta, and then some finds its way into the lungs, presuming there is an open VSD in a subpulmonary chamber. If the VSD is quite restrictive or the area underneath the pulmonary artery is quite narrow, there may be a critical reduction in pulmonary blood flow, in which case prostaglandin E1 will be required. Now, not all tricuspid atresia babies have this critical reduction. Some do not require prostaglandins, but some do, and this is true for other single ventricle defects that have restricted pulmonary blood flow. Finally, this is a rare lesion. Even large centers will see this only a very few times of the year, but it's worth mentioning. Ebstein's malformation basically is when the tricuspid valve is displaced into the right ventricle such that the right ventricular mass is reduced in functional volume, and the valve itself is very non-functional, so it tends to have marked regurgitation. There's a whole spectrum of Ebstein's. Very mild Ebstein's is consistent with an asymptomatic long life. Very severe Ebstein's shows up in the way I've illustrated on this screen, with a baby that has a massively dilated heart in utero and immediately ex utero, and a right ventricle that, by virtue of the tricuspid regurgitation, is basically insufficient to eject blood out the pulmonary artery and into the lungs. These babies require an open ductus in order to provide adequate pulmonary blood flow. The second general category of patients with cyanotic heart disease are those that have little or no obstruction of pulmonary blood flow and therefore do not require prostaglandin E1 for palliation. As I mentioned before, babies with tetralogy of Fallot rarely need a ductus. Most do not have severe right ventricular outflow obstruction, and so this would generally be the case for most babies with tetralogy. Babies with tetralogy of Fallot and so-called MAPCAs, or multiple aortopulmonary arteries, are patients that also oftentimes do not require prostaglandin for palliation. Babies with this particular lesion are like tetralogy in the sense that there are 2 normal-sized ventricles and a ventricular septal defect. The aorta generally comes off mostly the left ventricle, but instead of having some connection between the right ventricle and the pulmonary arteries, there is no connection, and blood finds its way into the lungs either through the so-called aortopulmonary collateral vessels or in some cases through an ductus arteriosus. Babies that do not have a ductus arteriosus and have supply through the aortopulmonary collateral vessels, of course, are not ductal dependent. And I've illustrated the angiogram on the right side of the slide as arrows pointing to these collaterals that come directly off the aorta. These babies are not prostaglandin dependent. I do hasten, however, to make note of the fact that some subset of babies with tetralogy of Fallot and pulmonary atresia will basically have their entire pulmonary blood flow supplied via a ductus, and babies with that lesion do require an open ductus and hence generally prostaglandin E1 palliation. Babies with truncus arteriosus do not require prostaglandin E1 unless there's some additional lesion, such as interruption of the aortic arch. Babies with truncus basically have two normal-sized ventricles and a VSD. And then there's a single large vessel that arises from these two ventricles that gives rise to both the aorta and pulmonary arteries. And this is not a ductal-dependent form of cyanotic heart disease. Babies with single ventricle lesions that have no obstruction to pulmonary blood flow do not require prostaglandin E1 in order to maintain adequate pulmonary blood flow. Now, I hasten to make note of the fact that some of these babies can have obstruction to their aorta, either flow from the ventricle into the aorta or coarctation or other narrowing of the aorta. In that case, prostaglandin E1 may be required, but simply talking about babies with cyanosis, cyanotic defects, if there's no obstruction to pulmonary blood flow in a single ventricle patient, there's no need for prostaglandin E1 in order to maintain adequate pulmonary blood flow. In the case of babies with transposition of the great arteries, prostaglandin E1 may be helpful. As you recall, these babies require mixing of the red and blue blood streams in order to provide adequate O2 delivery to the body. This generally has to, at least in part, occur at the level of the atrial septum. Mixing at the level of the ductus as a sole level of mixing is not adequate, but presence of an open ductus can increase pulmonary blood flow and augment mixing at the atrial level. And so for that reason, prostaglandin E1 may be helpful in babies with transposition. Not all babies will adequately respond to this, however, and there's an occasional baby with detransposition that actually becomes acutely ill after introduction of this medication for whatever reason. And so one has to keep this in mind, but by and large, ductal patency, maintaining ductal patency is helpful in these patients with transposition. Babies with total anomalous pulmonary venous connection, on the other hand, may actually be harmed by prostaglandin E1. If these babies have obstruction to pulmonary venous return to the heart, the resistance to blood flow through the lungs is very high, in which case, if the ductus arteriosus is open, blood that's ejected from the right ventricle tends to go across the ductus into the descending aorta, and hence total pulmonary blood flow is reduced. So with total anomalous pulmonary venous connection, one generally avoids the use of prostaglandin E1.
ICU therapy.
So finally, what is this ICU-based therapy that's available for patients that are hypoxemic? Well, basically, there are three things that one needs to do in order to effectively apply this therapy. The first thing is to assess and secure adequate O2 delivery for the patient. Even before one has a definitive diagnosis, it's necessary to attend to this. It's important when assessing the baby for life-threatening hypoxemia, by the way, to measure arterial oxygen saturations or PO2s. Transcutaneous oximeters are really not very accurate when the oxygen saturation is low and really aren't acceptable in many cases for determining whether a baby is seriously hypoxemic or merely has a lower than normal oxygen level. It's necessary to make ultimately an accurate diagnosis, and then eventually definitive therapy is applied, which is oftentimes surgical. but there is a considerable amount of opportunity to make these patients better even without surgery. So what is life-threatening hypoxemia? At least as far as I'm aware, there's no absolute arterial PO2 that qualifies for this. And so it's very important to think not only in terms of arterial saturation, but O2 delivery to the tissues. O2 delivery is the equation that describes oxygen delivery to the tissues is very simple. It's basically delivery equals arterial content of oxygen, which is related to both the pulmonary venous oxygen saturation as well as hemoglobin, and systemic blood flow, which is in a normal person, in a normal heart, cardiac output. One uses serum lactates and to some extent serum bicarb levels as indicators of tissue dysoxia. I don't think we know for sure that a non-elevated lactate level necessarily implies that all organs, especially the brain, have adequate O2 delivery. But as a general index of total O2 delivery sufficiency, a lack of high lactates tends to be somewhat reassuring. In general, I think one could say that with acceptable hemoglobin and cardiac output, at least in newborn babies, arterial PO2s in the low 20 range are tolerated at least for some period of time, and certainly arterial PO2s of greater than 25 seem to be well tolerated for at least some period of hours or perhaps even longer. But again, I emphasize that it's critical that the hematocrit be appropriate as well as cardiac output. If these determinants of O2 delivery are reduced, then that means that even with a marginally acceptable arterial PO2, O2 delivery may not be sufficient. So what can you do for a baby that has inadequate arterial delivery and saturations? Well, pretty much regardless of the form of disease, and this applies to lung disease as well as heart disease, there are a number of things one can do to improve O2 delivery. One can optimize hematocrit. I don't think anybody knows precisely what the very most optimal hematocrit is for O2 delivery, but it seems in general that hematocrits somewhere in the 45 range are probably pretty close. One can do one's best to obtain adequate systemic perfusion, appropriate volume infusion as needed. Inotropic agents can be very helpful. Time does not permit a full discussion of these, but the general use of these agents to improve cardiac output can be helpful in cyanotic patients. One would optimize ventilation, which oftentimes will require means mechanical ventilation, but not always. One can minimize total body O2 consumption through the use of chemical paralysis, mechanical ventilation, sedation, and temperature control. And finally, one can use therapy to reduce or eliminate acidosis, make sure glucose and calcium levels are acceptable. Prostaglandin E1 is a definitive palliation, although not permanent therapy for many lesions. It's certainly necessary when there's high-grade anatomic obstruction of pulmonary blood flow. As I noted, it's often but not always helpful in detransposition. And as also noted, it can actually be harmful with obstructed total anomalous pulmonary venous connection, or in any case in which systemic hypotension may be non-helpful. It's important to note that prostaglandin E1 is a systemic vasodilator, and when this medication is started, it's oftentimes necessary to use some degree of volume infusion or even inotropic and alpha-adrenergic agents in order to secure adequate blood pressure. One also needs to keep in mind that prostaglandin E1 also can cause apnea. This is especially true in prematures. It also seems to have an additive effect along with sedation, so that babies that are sedated for procedures or tests are more prone to apnea with prostaglandin E1, and one needs to keep this in mind. Babies that are transported shortly after E1 has been initiated, or even for that matter a number of hours after it, because sometimes the apnea that occurs with this medication occurs many hours later, one needs to consider whether or not those patients should be intubated. Whether or not intubation is indicated in this situation depends upon the exact circumstances, but one always needs to consider this before transporting the patient. The dose that's used to open a closed ductus with the E1 is 0.1 micrograms per kilogram per minute. For babies that already have open ductuses and one wants to maintain patency, we use a much lower dose. We generally use between 0.01 and 0.02 micrograms per kilogram per minute in order to maintain patency. As I noted before, it's important, if one wants to avoid apnea, to try to be ginger in one's use of sedatives in patients on prostaglandins. There is also at least one paper in the literature that would suggest that pretreatment with aminophylline, and one presumes that caffeine may have the same effect, reduces the risk of apnea in babies with prostaglandin E1 substantially. Definitive palliation for babies mostly with detransposition of the great vessels. There are a few other unusual circumstances, but primarily detransposition of the great vessels is really affected by Rashkin balloon septostomy. It's performed by skilled personnel, generally well-trained pediatric cardiologists. It can be done at the bedside using echocardiographic guidance or in the cath lab. There's a relatively low risk of complications with this procedure, but the ones that do occur can be very serious. There's a risk of air embolism because of the technical features of the way this is generally done. Also some risk of injury to systemic or pulmonary veins or AV valves. And so it's important that the hands performing this procedure be skilled and experienced. Many babies that have this particular procedure, by the way, still require an open ductus for adequate oxygen saturations. Simply having an open atrial septum does not always ensure adequate mixing. This is an angiogram of a baby with detransposition that has a Rashkin balloon septostomy catheter placed in the left atrium. The catheter came up the inferior vena cava, crossed the foramen ovale, and the balloon was inflated, which, by the way, has contrast, radiopaque contrast material, and it was inflated. You see the balloon is briefly advanced and then forcibly pulled across the atrial septum into the right atrium, as illustrated here. Finally, I'll just briefly mention that there are a few unusual situations that you might wind up encountering that will require slightly different therapy. There are a few, but not many patients with congenital heart lesions that have increased pulmonary vascular resistance, much as is seen in persistent pulmonary hypertension of the newborn. The only lesion in which this is seen with any frequency, and even in this case it's unusual but not unheard of, is detransposition of the great vessels. These babies occasionally have very high resistance, which to some extent is oftentimes responsive to inhaled nitric oxide or other vasodilators, and tends to resolve after a few days. These patients may require nitric oxide or even ECMO support in order to support them while their vascular resistance is falling postnatally. Babies with congenital heart disease that have persistent findings of significantly elevated pulmonary vascular resistance are quite uncommon and make one think of the possibility of alveolar capillary dysplasia, which has been described in a number of congenital heart lesions, especially left-sided obstructive lesions. Some babies with right-sided obstructive lesions, especially tetralogy of Fallot, will have a congenital absence of the ductus arteriosus. If a baby has no ductus and severe outflow tract obstruction, Prostaglandin E1 will not be of any use in palliation, of course. These patients can be treated, sometimes palliated for some period of time by increasing their systemic vascular resistance so as to effectively force blood across the high-grade obstruction in the right ventricular outflow tract. Phenylephrine is most typically used for this. ECMO support can be useful. Sometimes these babies can be treated in the cath lab by placement of a stent out the right ventricular outflow tract in order to open this up sufficiently for adequate PO2s. Patients with obstruction of the of total anomalous pulmonary venous, anomalously connected pulmonary veins require emergency surgery because there's really no effective form of palliation other than very short-term ECMO under unusual circumstances. So by and large, these patients require prompt diagnosis and prompt definitive surgical therapy. Finally, to finish up the lecture, I'd just like to spend a few minutes talking about ICU therapy for patients with single ventricle physiology and unobstructed pulmonary blood flow. Patients with this combination of defects tend to develop over the first few postnatal days excessive pulmonary blood flow. And the reason is, of course, is that normally resistance to blood flow through the lungs is much lower than the body. And as pulmonary resistance falls, and it tends to fall quite rapidly after birth, these patients actually tend to send more and more blood to the lungs and less blood to the body, since the heart can only pump out a total amount of blood, a volume of blood at any one time. These patients tend to have only mild hypoxemia. Their saturations are in the 80s or even 90s. And there's a tendency for systemic blood flow to be reduced due to excessive blood flow into the lungs. Typical lesions that have this are truncus arteriosus, who generally, in most cases, do not have obstruction of the pulmonary arteries, hypoplastic left heart, or any single ventricle defect with unobstructed total pulmonary blood flow. This is a slide that I had shown in the previous part 1 lecture that relates the total amount of pulmonary to systemic flow, the QP to QS, to oxygen delivery. As you may recall from the first lecture, as QP to QS goes up beyond a certain level, the blood that goes to the lungs effectively is blood that's stolen from the body, given the fact the heart can only pump so much blood, and as a result, the total amount of O2 delivery, which is of course dependent upon not only arterial saturation but also systemic blood flow, tends to go down. These are computer-generated curves that relate QP to QS to systemic O2 availability, which is the same as delivery. And what it shows, and I put a red circle on the graph to indicate the amount of total cardiac output that most neonates generally have. And as the QP to QS goes much more than a little bit less than 1, the total O2 delivery to the body actually falls, even as the arterial saturation goes up. So it's important that these patients be managed in such a way that the natural tendency to have too much pulmonary blood flow is not encouraged. And the way we do that is we avoid therapy that decreases pulmonary resistance. We avoid hyperoxia and alkalosis, both of which tend to vasodilate the lungs, pulmonary vascular bed. We avoid systemic hypertension. As systemic vascular resistance goes up, this tends to force more blood into the low resistance pulmonary circuit. Patients like this may also benefit somewhat from inotropic support in order to maximize their cardiac output. Diuretics can be helpful since they tend to accumulate some fluid in their body and their lungs. An occasional patient may benefit from some ambient oxygen, FiO2 in the 15 to 16 range or so, if in fact they show signs of decreased systemic perfusion. We actually don't tend to use that very much in our institution, but under certain closely monitored circumstances it may be helpful.
Summary.
So to summarize, it's important to identify cyanotic lesions that seem likely to have congenital heart disease so that prompt diagnosis can be undertaken. one can certainly base diagnosis as best as possible on, or base therapy as best as possible on specific diagnoses. And prostaglandin E1, when used appropriately, can be very helpful. Even before one has a specific diagnosis, I should emphasize that for severely hypoxemic patients, generally speaking, the likelihood is greater that you will help than harm the patient with prostaglandin E1. So, especially if one is dealing with life-threatening hypoxemia, waiting for a specific diagnosis to initiate prostaglandin E1 would generally not be the appropriate thing to do. If the baby, upon being started on prostaglandin E1, becomes hypotensive or more hypoxemic, one may need to modify that therapy. But one should be relatively liberal in one's use of prostaglandin E1, absent specific contraindications. And finally, and this is a very important point, some therapy, for example, optimizing hematocrit, minimizing O2 consumption, and promoting adequate systemic blood flow is helpful for just about anybody with severe hypoxemia and can be applied even when there isn't a specific diagnosis while one is waiting to do that. Thank you very much.